It's the AEMT lecture series. Welcome back. This will be video number 2 for chapter 17, respiratory emergency. So let's pick up where we left off. We were talking, we're going to talk about the pathophysiology of respirations, and there are 4 areas that we need to concentrate on when we're trying to critically think about a respiratory emergency. And one, do we have an upper airway or lower airway obstruction? Do we have something mechanical going on where we have a pneumothorax? Do we have a flail segment? Do we have a diaphragm injury? All right, and then we need to look at the neurological aspect. Do we have a CNS problem? Is the respiratory center of the brain? You know, we could be dealing with an infection there or an injury. All right, so they mentioned the 2 types of cells here for the alveoli. I don't want you to get too hung up on that. Just understand type 1 is going to be your alveoli that are functioning perfectly. If these get damaged or wiped out due to an injury, due to a smoking, etc., these are not going to replenish. They're not going to regenerate. Type 2 can grow into a type 1 alveoli, but again, if they get to the point where they're damaged beyond return, they won't regenerate. Alveoli, they do function best when they are inflated. It's kind of like the book uses an example of a balloon. If you had to blow a balloon up, just out of the pack, well, it's going to be difficult sometimes, depending on the size. But now, if you had a balloon that's already partially inflated, much easier task to do, right? Well, you can use that example with surfactant. Surfactant allows those alveoli to never completely close, keeps them open to an extent, and allows that surface area to be larger when it comes to gas exchange. So when we're talking about perfusion, right? Pulmonary capillaries, they're going to allow oxygen in from the red blood cell, and they're going to, through diffusion, right? You're going to get rid of the waste the same way. But there is something that's specific to this. Let me get the old pen out here. One second while I shuffle my notes around and try to get things organized here. Sorry about that. Actually, you know what? Before I do that, let me do this. Let's flip back a couple slides and look at an alveoli right here. All right, so when we're looking at this, at the alveoli, then I want you to take a look at your vessels here. So this is going to be the pulmonary artery. Okay. And this is going to be the pulmonary vein. And the reason why we know that is because the pulmonary artery is going to be carrying deoxygenated blood to the alveoli. It's going to drop off the CO2, pick up the O2, and it comes back as oxygenated as color red. Means it has hemoglobin, all right? And that hemp part of hemoglobin means color. But look at how narrow these vessels are when you get down to the alveoli. And there's a reason for that, because they become very small and they can get very, very close to the alveoli, and that allows for gas exchange. But how this works is like this. So here's our pulmonary vein. Okay, and here's our alveoli here. Because that pulmonary vein, those pulmonary arteries, again, they're very close to the alveoli. And so what we have in the pulmonary vein, we have these red blood cells. All right, so you have your red blood cells. All right, so now I want to talk about what's going on and patient condition here. So let's say we have a COPD patient. And with COPD, they're chronically in respiratory distress. All right, so they have a chronic elevated carbon dioxide level. Chronically, their pulse ox or their arterial blood gas is a little low. Okay. And what this signals is to the brain is, look, we're not breathing very well. So let's make more red blood cells. So imagine now all the red blood cells crowding in here. They're packed in there, but you notice that looks like they're all in a single file line. They're in line, right? They are, because the vessel's so narrow. You can't have two or three stacked on top of each other. And since now we've called upon the body to produce more of these red blood cells, we have increased the alveoli pressure. So we have alveoli pressure that's increase in pressure. And that's gonna be felt by the heart, right? Because remember, the heart here, we sent that blood over there, right? So we have our four chambers here, and then this is your right atrium, right ventricle. That right ventricle sent that blood up the pulmonary artery to where it is now, right here. And there's pressure now. Pressure because these guys they're struggling because they're all packed in on top of each other. Not literally, because they can't literally. Not enough room. But they're all trying to get out through diffusion. That's going to increase that pressure in the right ventricle, and that's eventually going to cause the right ventricle to fail. So that is called cor pulmonale, and it's a problem, something to think about. So right ventricle failure can cause respiratory distress. All right, let's talk about hypoxic drive. All right, so hopefully everybody knows that we are remember earlier when I said the brain sends the stimulus to breathe, and it does. That stimulus is read, though, by our CO2 readings, our carbon dioxide level readings. That's how our body works. If our CO2 gets high, then our body says we got to breathe faster to get rid of it. If our CO2 level is low, well, we're going to breathe slower to retain it. And the reason why the body chooses that is because there's reserve oxygen in the alveoli. Okay, that's how come when someone goes into cardiac arrest, we're able to circulate oxygen through CPR to call upon the reserves. The body knew that it would be a false reading. It would show that it was doing much better than actually was. So it needs to reach CO2 for that reason. Now, after a period of time, the body, in someone like a COPD patient, emphysema, the body starts getting used to those high CO2 readings, and it becomes concerned because it knows now that the CO2 might not be a very reliable reading. So it switches. It's got a backup system in place, and the backup system says, hey, we need to switch to reading oxygen rather than CO2, and so that's called a hypoxic drive. All right, so hypoventilation, low ventilation, can come from those same four areas that we talked about. Hyperventilation, we already know what that is. It's rarely a problem for us. Usually corrects upon itself. Causes of dyspnea. Now, how about I can never say the word, anaphylactic? Failure of the lung to want to stretch properly. The lung tissue becomes very compliant, and it doesn't want to stretch. So, if the lung doesn't expand all the way, then the alveoli won't expand all the way. So it becomes a problem. Damage to alveoli from earlier, chemicals, smoking, anything like that. Obstructive air passages. Do we have a patient who has asthma, pneumonia, and those bronchioles are becoming filled with pus and infection? They can't pass air. And then the pleural space. We talked about that earlier with a stabbing that occurs where the chest wall is has some type of embarrassment and begins to fill with air because we have a vacuum. Severe pain can come from severe respiratory distress because you have those intercostal muscles in between the rib cage, and they're working hard, and they're not used to working that hard, and so they're working very hard, and it can be very painful. Upper and lower airway infections. We see the croup, most common in 2-year-olds and younger, viral type infection. Common, that seal type cough. But then you have epiglottitis that we don't see as much anymore, thanks to vaccinations. Kids aren't dying from this anymore, and it's almost been wiped out. Then we have acute pulmonary edema. Okay, and the slide here says not every patient with this has heart disease, and they're right. I mean, you do not have to have heart disease for this to happen. I'm going to pull up a picture here. Okay, we're back, and so take a look at this. We're talking about congestive heart failure. So let's look at this. Let me get a pen. All right, let's make it big too. Bam. Okay. All right, so we have a left ventricle here that's very large. Okay, I'll show you another picture in a second, but this thing is maxed out due to preload. Okay, so the pressure inside this circuit here has become so high that the left ventricle had to pump against it, and anytime it has to pump against the pressure, it has to get blood up. It's already pumping up, but take a look at this. It has to get it up around the curve, and I call that the aortic curve. And then look what happens here though. It's going to drop. It's in free fall mode now. So all that extra velocity that the left ventricle used to get this blood out of it, now it's coming down very fast. Okay. And that's what causes edema, because when you get down here to your feet, your hands, it's just like the capillaries. Okay, it's just like the capillaries in the around the alveoli. Okay, and so we know that this blue right here is going to represent plasma. It represents the plasma, okay? And you have cellular blood in there, right? You have your red blood cells, your white blood cells, and your platelets. They're not going to make it through the membrane, but the plasma will, because it's mostly water. And when it starts rushing down, it's rushing down. This artery becomes an arteriole because it becomes smaller, right? Just like veins become venules. You get down there to the capillaries of your hands and feet. This water is coming at such a velocity that it's going to start leaking out. And that's where you get your edema. Okay, so here we have that problem. Well, the same problem will exist when you get down here to the alveoli. All right, so here you have your pulmonary artery. Okay, and it gets down here to the alveoli, and the same thing happens. Those vessels become smaller. You got your plasma. It's going to leak out. Where's it going to go? It's going to go down here around these alveoli down here. And once it covers those alveoli, they can't have gas exchange anymore. They're covered in fluid. They're covered in fluid. So these patients are normally, and this is not a heart attack. Okay? This has nothing to do with the heart, other than this left ventricle is so big now that it can't pump correctly. So we have an increase in the pressure. You're going to see it. Your blood pressure is going to be increased. Okay, your pulse rate is going to be increased. You're going to have your edema. Okay, and this edema is going to, when you listen to these lung sounds, it's going to sound like rhonchi. And you'll hear it around these lower bases. Patients can become very sick from this, and they can die from this. So here's the normal cardiac output, normal blood pressure, aorta. See how see how here the left ventricle is represented here. The normal heart. And here's your decreased cardiac output. Let me show a better picture. I don't like this picture. Here's your healthy heart. Here's your left ventricle. You see how much of this, how small it is? Compare it with here, how large it is. It just can't pump against it. Pressure is too high and it can't pump against it. And it affects gas exchange. All right. Orthopnea. So ortho doesn't mean bones, does it? It means like being straight. All right. So when the patient walks, they become very distressed, fatigue, reduced in their. They're not going to be exercising, and they're going to have some pulmonary crackles. COPD. This is a slow process, it says, and does disrupt the airways. Most commonly seen, definitely in cigarette smokers, people who've had injuries to their alveoli. Your chronic bronchitis patients. Pneumonia is almost the same as your emphysemas, except they're not usually in so much distress. Once the infection is cleared up, they're much better. Repeated episodes of pneumonia can lead to COPD. These patients usually have a chronic cough. Here's a patient with acute COPD, and first thing we notice is what? His chest. It's a barrel type chest. Looks like a barrel. They have pursed lips. That helps something in there that they don't have anymore. A lot of they have poor compliance. Their lungs do not want to stretch out as like they used to, and so that pursed lips helps to keep pressure into the alveoli. Just any amount of pressure that it can extend to the alveoli. You guys know all of this. I mean, this is EMT stuff. There's nothing new here that you don't know. Asthma, bronchial spasms, all that's familiar to you. Anaphylaxis can cause problems because of the bronchial constriction. Those bronchioles become extremely tight and you can't breathe. Here's the spontaneous pneumothorax I was talking about earlier. See, you have air that's being drawn in because of the vacuum created. And once that pressure increases so much, it will collapse the lung. A spontaneous pneumothorax is usually one that happens within inside the body itself. There is no injury to the pleural space. It's usually something called from a blevy to the lung. It's a weak place in the lung. It causes it to start releasing air. And so instead of having air come from the pleural space, you actually have air leaking out of a blevy and increasing pressure inside the thoracic cavity causing problems. It's usually slower to present than a pneumothorax. Here's a pleural effusion. Sorry, one second. A pleural effusion, the collection of fluid outside of the lung or on one or both sides of the chest. Patients usually present with decreased breath sounds. You can actually hear the fluid there. Sounds like crackles. You could a lot of times though their breath sounds will be decreased too, where you can't hear it. And the treatment is just to get rid of that fluid, to remove it. They'll actually stick a needle in and draw it out. Pulmonary embolism. This is when you get a blood clot, usually in the pulmonary artery. This blood clot is large and it doesn't allow blood around it to get to the alveoli to have that gas exchange. So a lot of these result from a clot that started in the lower extremity and has worked its way up. So you have to be very suspicious for folks that have been immobilized for a while. Maybe they've had surgery, a hip fracture, something that's kept them immobile. I'm breezing through here because you guys don't need all of this. This is all stuff you've had in EMT school. I'm just looking for, trying to see if there's any type of new physiology that we need to cover, or, maybe something that you need a refresher on. And I don't see any. Okay, guys, this is going to do it for respiratory emergencies. Just the 2 videos this time for respiratory emergencies, and I will see you guys with the next video shortly.